right, everybody, we're going to go ahead and get started. And so, good afternoon. My name is Rin. I'm a forensic interviewer with Child's Voice, and I'm here to introduce Nathan. And so, just a little bit about Nathan. Nathan Kringstad is a CSW. He's a mental health therapist specializing in trauma-focused care for children and adolescents ages 7 to 18. Nathan joined Child's Voice as our first mental health therapist in 2023. Nathan has prior experience in youth psychiatric residential treatment, foster care treatment, school-based mental health, and adult inpatient mental health. Nathan has extensive training in trauma-focused cognitive behavioral therapy, TF-CBT, and advanced training in TF-CBT for treating problematic sexualized behaviors in youth under 12. And so Nathan will get started.
Awesome. Good afternoon, everybody. Is the microphone working? All right. Sweet. Well, I'm Nate Kringstad, behavioral health therapist. Thank you, Rin. I get the opportunity to talk to you guys about problematic sexualized behaviors with kids and children and youth. I do want to make a quick note. I did make a quick change to my slides. Before it said children and adolescents or children and youth, I changed that to adolescents just for cohesiveness and clarity throughout the presentation. So today we're gonna answer a couple of questions about problematic sexualized behaviors. First, I kind of want to point out, I think this is an area, at least from my perspective, that maybe has a lot of myths behind it or a lot of misunderstandings on what sexual behavior is and what problematic sexualized behaviors are. And so I know this can be an uncomfortable topic, at least in my therapy practice. Talking with parents, this is a very uncomfortable topic because it's not something that parents are easy to talk to about, or that I should say maybe a lot of us in this room maybe aren't super comfortable talking about problematic sexualized behaviors or just even sexualized behaviors with kids. I'll be honest, I wasn't when I first started as a behavioral health therapist with Child's Voice. So a way to frame our presentation today is going to be answering a couple of questions. First one is, what is problematic sexualized behaviors? How and why do these behaviors develop? And what do we do to intervene clinically? And then lastly, what can you do to help? In whatever profession, whatever education, wherever you are at, how can you help professionally? So a little bit about me. I know Rin kind of gave an introduction for myself. So I've been at Child's Voice, Child Advocacy Center, just across the way for the last, going on my third year here, just finishing up my second year. So I've been working on the mental health side of the Child's Voice work. I've been doing trauma-focused cognitive behavioral therapy with the kids who are impacted by trauma. So I treat a lot of trauma with problematic sexualized behavior, anxiety, depression, oppositional defiant disorder. It's kind of more of my specialty in the areas that I work in. So I have the training in TF-CBT and then also the advanced training with problematic sexualized behaviors. We'll talk more about treatments for problematic sexualized behaviors and the clinical interventions. To be honest with you, there are only a few evidence-based approaches, and that's kind of where I'll be talking from. However, therapists have been treating problematic sexualized behaviors in children and adolescents for a while, and there's some different other modalities and approaches. So there's some variability in that, but I'll be talking more specifically on the evidence-based approaches and treatment. Along with Child Advocacy Center that I work with Child's Voice, I also help out at the Children's Castle from time to time doing the STEP screeners for trauma, and then also help out with the Sanford summer camps, so Camp Bring It On, Spirit Camp, helping out there in my behavioral health role and helping out the program. And then, as mentioned before, worked in treatment foster care, worked in youth residential treatment facilities, and then also the adult inpatient mental health over at Avera Behavioral for a while. So I haven't used Slido. However, if you guys online and in person, if you want to use your phone to interact, a couple of things I have going on is a question and answer. I know we save that for the end. However, you can put in your questions at any point in the presentation. If you scan that right now, there's a couple of other spaces. Pretty much at every major break in my presentation, you can log in and ask a question, and we'll get to that at the end of the presentation. And there's also some knowledge quizzes, if we want to call it that at the end of our presentation today. So what is problematic sexualized behaviors? We'll be defining what PSB is in children and adolescents. And then in this area, we'll be differentiating between normative and problematic behaviors. So the definition, the consensual definition that we have is child and youth initiated behaviors that involve sexual body parts, the genitals, anus, buttocks, and or breasts in a manner that is developmentally inappropriate and potentially harmful to themselves or others. So this is the agreed upon definition for problematic sexualized behaviors in the literature, especially moving in more recent times. In the last 10, 15 years, we've used more of the language of problematic sexualized behaviors. Previous language behind it focus kind of more on the offender language. And so we want to focus more on the behavior, and that's something I'm going to come back to. But to really note, and I'm going to probably say this like a broken record several times throughout this presentation, on this behavior is developmentally inappropriate and harmful when we talk about the harmful behaviors. So we'll break it down to normative, concerning, and harmful behaviors for PSB. And then to note, this is children. With adolescents, so that age 13 to 17 age range, when we talk about problematic sexualized behaviors with this demographic, the challenge is that gets to more into the legal involvement. So we're going to have court involvement, child welfare involvement in those cases more often than not. So we look at those behaviors often being in the legal side. We do call those more of the abusive behaviors, harmful abusive behaviors, and we see those as more on the legal side. We'll come back to that. That's why we're differentiating between children and adolescents when it comes to problematic sexualized behaviors. Same thing with sexual development. We'll touch on that throughout this presentation. Is sexual development obviously changes throughout ages and demographics. Not demographics, throughout the ages. And so we want to separate the adolescents, especially with puberty, and then what sexual behavior is normative in adolescents. That's why we're separating the two areas, especially in treatment too. Treatment approaches is vastly different between the two demographics. If I can get you guys to remember one thing from this whole presentation, it's this, is that the problem is not the child, the problem is the behavior. The problem is not the child, the problem is the behavior. I know oftentimes when we think about how do we define these, or how do we go about talking about kids with problematic sexualized behaviors, we sometimes treat them as mini offenders. And I want to step away from that language, caution that language, try to avoid that language, and remind ourselves that these are just kids. These are kids. A lot of them have had things happen to them or have had poor modeling of what healthy sexuality is in the home, or they've had other vulnerabilities that we'll discuss throughout our presentation. And so I want us to really focus again. We're looking at the child's behavior, and not them as the identity as a offender. So why our language matters. It's about what they did and not who they are. So again, try to avoid terminology such as predator, pedophile, child molester, sex offender, sexual deviant, serial rapist, psychopath. I know in the adult world, it's a bit of a different approach. However, when we talk about kids and even teens, being cautious, but when I think about the age demographic that I primarily work with, the 12 and under, calling a 12-year-old a predator or a pedophile or a child molester doesn't sit right with me. And so using more person-centered language, focusing on the behavior, so using sexual harmful behavior, sexually reactive behavior, abusive reactive behavior, really focusing more on language instead of perpetrator to initiator. So in the language that I use with parents and with kids too is focusing on the initiating child and the impacted child. In my practice as a therapist, I work with both in different cases, working with the initiated child and also, but more often, the impacted child. So that's doing the trauma work that I do with the impacted child. So what is problematic? Kind of I mentioned before, we're breaking it down in between three major areas: normative, concerning, and harmful behavior. So when we think about how do we approach the normative behaviors? These are things that we'll monitor through interaction, conversation, education. When we see things come up, great teaching opportunities for parents. And so this is maybe one thing I want to get out of the presentation too, is when you interact with parents, language that you can use or ways that you can approach sharing these thoughts with them and finding out what normative behavior is. We'll talk about each of these areas in the next couple of slides. But what do we do to intervene? It's mostly monitoring through interaction. When we notice concerning behaviors, that's intervening, monitoring, and reassessing. So take note, monitor that, intervene when you need to or when you can to redirect behavior. Let's say a 4-year-old, we have an example later on in the presentation, little Sally, mom is changing the diaper of her 1-year-old, and little Sally comes up, 4-year-old, wants to see and touch her brother's penis, and mom, calmly calmly intervenes. Nope, we don't touch other people's private parts. Use it as a little bit of a teaching moment for okay touch and not okay touch. And so that's just a little bit of intervening. Now, when these behaviors don't stop after intervening or they become harmful, that's when we think about intervening, assessing, and responding in treatment, responding a little more heavily than just redirection of behavior. So what is normative? These are behaviors that are developmentally, biologically, socially, and culturally within normative expectations. So these respond to intervention. They respond to, oh, we don't touch other people's private parts without asking. Then if they stop, great, it's normative behavior. It's more exploratory. There's curiosity associated with that. Think about this from the 4-year-old range. It's exploratory, not exploitative, and there's familiarity between children. Also, another important point is if it's between unknown children or strangers, acquaintances. This is what we're getting at here is like siblings. Sexual behavior between siblings is relatively common. I don't have the exact stat off the top of my head. However, we do know that the more explorative, age-appropriate range is relatively normative. Kids play doctor all the time. They play house all the time. It's not necessarily a bad thing that you want to dissuade. However, recognizing that's great teaching opportunities when something does come up. So, an example. Let's use the example of a 5-year-old to 9-year-old. 5 to 9-year-old range. So a child touches or rubs her own genitals when going to sleep or when feeling happy, scared, or because it feels good. This is developmentally normal and not inappropriate in any way. Another example for a bit older, 10 to 12-year-old, child's interested in sex and sexuality. They may use different forms of media, internet, social medias, movies to explore sexual content or ideas. This is normal getting to that 12 preteen age range. Once you get to the adolescent age, it's rather very normative, and we'll talk about that at the end of this presentation. When we think about concerning behavior, we're noticing a difference is that this is starting to create adversity, is creating an adverse response to anxiety in the other child, or sometimes even anxiety for the child themselves. There's excessive frequency, duration, intensity increases. So this is developmentally incongruent, requires more intervention, and we notice that these things are happening more secretively, and not just in private, but they're being hid away from parents or hid away from other adults, caring adults. And also to note, the situation and context is not appropriate. So an example, 5 to 9-year-old. So the example from before is going to carry on between normative, concerning, and harmful to help delineate between the two, or the three. So the 5 to 9-year-old range, child shows genitals in public, continues to touch or rub her genitals after being told no multiple times. So we would say this is concerning because she's being told not to do that multiple times, but it continues to happen. So with the 10 to 12-year-old, that child who was wanting to seek out sexual material, this child is spending considerable amount of time seeking out these images, including porn online. The behavior impacts the school relationships, school, work, family, and friendships. So we're noticing that this is maybe requiring more intervention. It's becoming more secrecy and not just private, and the context is inappropriate. Now, the harmful range. Harmful is anything that's physically, emotionally, psychologically, and or developmentally harmful. I know this probably sounds intuitive to all of us, but this is behaviors that are exploitive. There's a fixation. The child does not respond to redirection, or you tell the child no multiple times, and it just does not stop. There's extended adverse response in either of the childs. That's the anxiety, the fear, the sadness, and withdrawal. The thing is, that we've talked about before, preteen behavior is usually developmentally on track. And there's usually increasing sexual behavior such as masturbation and preoccupation with the other gender. As you get into the adolescent age, that becomes more normal. However, the problem is when it becomes exploitive and there's a fixation again, and you notice that anxiety, the fear in the other child. So 5 to 9-year-old, that child is showing their genitals at school and other public places, and doing that maybe in a way to express anger or defying authority. So noting maybe the emotional dysregulation in that child as well, something to treat in therapy. The 10 to 12-year-old range, after being caught, so this child who was looking up pornography or looking for sexual material, and and access is taken away, this child continues to seek it out, continues to try to find different ways, different opportunities to find that material. And if they can't find it that way, they might be making their own through drawing, through videoing, through pictures, those kind of things. Or to note in here, watching violent porn, child porn. I do have a slide we'll specifically talk about sexually explicit material, which will put pornography in with that range or within that distinction. So we'll come back to that again later on. So what's typically healthy developing or healthy sexual behaviors in children specifically? These are behaviors that are intermittent and with mutual agreement and assent. So again, playing doctors, you have 2 5-year-olds who are curious about each other's bodies. Mom walks in and sees them doing that. Great teaching opportunity of, yes, bodies are different. Your sister's body is different than your body. You have a penis, she has a vagina, and using language that is appropriate with kids. Similar age, size, or development can be influenced by intervention supervision, as we talked about, not associated with higher levels of fear, anger, anxiety. These are behaviors developmentally congruent and exploratory, mostly spontaneous. Maybe to mention there too, that they are not, with the spontaneous behaviors, oftentimes when we see harmful behaviors, they're pre-planned. They are, or maybe not necessarily pre-planned, however, that can be a component to it. But again, with that fixation, it's the desire for wanting more. So determining what's unhealthy in sexual behavior in young children, behavior that is, whether the judge decide if the behavior is common or rare for the child's developmental stage and culture. To note in here too, when we talk about what's sexually appropriate for kids, context matters, culture matters. This is a bit tough to define sometimes. However, this is where conversations with parents, education is really important. We'll come back to that more in the parent approach and how to encourage parents with education. But a lot of this is also understanding what is normal for the patients that you're working with or whoever you might have and having those conversations. So it's understanding the behavior violates a shared cultural norm or expectation, noting the frequency of the behavior if it continues to happen, to the extent to which sex and sexual behavior has become a preoccupation for the child, and whether the child responds to guidance and correction from adults or continues after healthy corrective efforts. So kind of repeating myself at this point, however, want to really focus on that culture aspect, culture understanding for what these kids in their family systems look like. Keep in mind, I mean, I think I said this at the beginning of the presentation already, but children, we're all humans, are sexual beings. And so from even at the youngest age, discovering what our body is, what it looks like, things that feel good to children, and again, teaching moments and teaching throughout the lifespan, as we'll talk about. So why is it so hard to define problems? Kind of as I already said, we have to start using that developmental contextual lens to understand like what is problematic. We have there's more agreement on what behaviors are problematic than what behaviors are developmentally expected, especially in older kids, because we can define and say, hey, that's not appropriate in an older child than what it is for a younger child. And so these conversations, again, sometimes uncomfortable, being able to understand maybe more, instead of saying a child can do this, this, and this, we look back to those guidelines that we were just talking about that appear quite frequently and think about, does it fit within these bounds? Is it developmentally appropriate? Is it age? Is there exploratory behavior to determine whether something is normative or not? Also to note, a lot of the data that we have on what is normative behavior comes from before 2010. And so a lot of this stuff is a little bit older, and we are currently, research is always updating on what is normal and what's normative for kids. And also defining what is a problem is also a challenge and requires maybe some collaborative approach with parents. And it's not just, here's the answer, this is a problem, but really looking at the whole situation. Prevalence rates. How often do these sexual behaviors happen? Well, with sexual behaviors with kids, 40 to 73% of kids display some sort of sexual behavior before age 13. So pretty prevalent. Approximately 6% of kids who are receiving mental health treatment might have a severe issue with problematic sexualized behaviors. 25 to 40% of child sexual abuse cases involve just children. So these are child on child acts of sexual abuse. And oftentimes in the CAC world where I work and exist in, these are the cases that we work with, is these child-on-child cases. And when we talk about, age 12 and younger, there's not a whole lot of maybe mutual understanding or resources on what do we do when this happens? How do we treat this? How do we go about this? Rather than just kind of sweeping it on the rug and hoping it doesn't happen again. Education, education, education with parents, and intervening when appropriate with mental health treatment. Interestingly enough, gender makeup, girls have the majority of cases in preschool. So oftentimes these cases will come up and they're more common in girls in preschool age, but then once they hit the school age, it's the boys that typically have higher rates of these problematic sexualized behaviors. So turning to the adolescent side, kind of already mentioned this, but what does it look like for the adolescents? This is adolescents who have engaged in sexually abusive behavior or may be at risk to engage in sexually abusive behavior. And as I already mentioned, oftentimes these cases are already involved in the child welfare or juvenile justice systems. And so thinking about a multidisciplinary approach, again, what happens with these adolescents is we do oftentimes see them as mini sex offenders, or we see them as that's what you're going to become. And we put them through kind of a pipeline, or we put them into sexual offender treatment. We have plenty of research on recidivism rates, which we'll get to at the end of the presentation. However, really thinking about, is there a better way we can treat these kids? Is there a better way we can look at their behaviors as the problem versus them as the identity of being a sexual predator? And so thinking about what resources, what ways can we intervene? We'll talk about that on the clinical side in a bit. So prevalence rates of adolescents with problematic sexualized behaviors. It varies, but on average, adolescents initiate 25% of rape cases and 35% of child sexual abuse cases involve adolescents. So kids between age 13 to 17. About 9.8% of children between 14 to 20 had initiated some unwanted sexual behavior with another person. To be mindful again, when we talk about data and sexual abuse, oftentimes cases go unreported. And so this is, just keep that in the back of our mind. So that's when we have that 9.8% of children initiating some unwanted sexual behavior with another person. Having that in mind as we think about this data here. So these things happen. This is a problem. We have to do something about this. We have to intervene. And where we would ideally want to intervene is before the problem ever happens and ever shows up. Again, education, talking about this problem, talking about these behaviors. So normative sexual behaviors in adolescence, really we're kind of thinking this gets to more into the adult range. Once we hit puberty, once we hit adolescence, we start to see that full range of sexual behaviors that we would see in adults. So this is oftentimes behavior that is concerned with one's appearance and body, defining sexual identity accompanied by confusion. Full range of adult sexual behaviors are prevalent, abstract thinking, and full physical maturation. Risk-taking without understanding of consequences. I don't know if anybody in here knows a teen that doesn't take risks without knowing the consequences. This is, again, education. When we talk about these things, it's not just one conversation, but it's several throughout the lifespan. And then experimentation with sexual behaviors. So these are normal for adolescents. That's why we're differentiating between the two. And I think I specified this at the beginning of my presentation. Clinically, I don't work with adolescents. I don't have that level of training for this, nor do I have the training for the evidence-based approach that we have. So my focus is mostly with kids under age 12. So just to note, there's not going to be a ton of adolescent information in here, aside from psychosexual evaluations we'll talk about, and then also how I understand and would know about the evidence-based approaches with adolescents. So why is it challenging to differentiate experimentation and exploitation? Well, kind of as we mentioned, the age difference, asking, is there an imbalance, chronological and developmental? Obviously, we know this, but there is the chronological age of a child, but also the developmental age of a child. So when we have a 6-year-old age-wise, and there's the problematic sexualized behaviors from let's say a 11-year-old, but who is at that 6-year-old age developmentally, this is where it's difficult to recognize, is this problematic? Is this normative? Does it, think about it from the other areas that we've looked at, does it go away after we intervene? What's the frequency? What is the harm to the other child? How has the other child been harmed, the impacted child? So play, is the play mutual? Is there assent? Is there agreement and reciprocity in the play? It's not aggressive, it's not forced, there's no coercion in the play. Adverse reactions we notice, is there anxiety? Is there fear with the other child? Is the behavior increasing in frequency? Is it happening more often? How many? How long? How much? These are the questions we ask. And then lastly, environmental. Is there technology involved in some way, shape, or form? What's the social impacts? What are the influences that this kid has had, the family has had? And then what's the impact? So an example, a child causes physical injuries such as bruising, redness, or an abrasion on themselves or another child, or causes another child to be highly upset or fearful. We would call that harmful. So that was a lot on what is PSB. We'll get into how and why do PSBs develop. If you want to access the question and answer and put a question in at any point, you can. There's that link to the Slido right there. So we'll be understanding the connection between problematic sexualized behaviors and trauma, risk factors and protective factors, and then the recidivism rates. So vulnerabilities and risk factors. There is not one single factor that causes problematic sexualized behaviors. When we think about PSBs, there are a variety of risk factors that go into this. Not all kids that have experienced sexual abuse will develop problematic sexualized behaviors. In fact, it is very few of them that actually will go on to develop problematic sexualized behaviors after sexual abuse. However, we do know that trauma, particularly physical abuse, has a high impact on kids who do have problematic sexualized behaviors. So in that little Venn diagram here, we think about the vulnerabilities, modeling of sexuality in the home, family adversity, modeling of coercion, physical or domestic violence oftentimes is something that comes up quite frequently in kids with problematic sexualized behaviors, or seen that in the home. So exposure to violence in the home or in the community, or neglect, traumatic experiences, lack of emotion regulation, conflict resolution, impulsivity, poor modeling of education of sexuality. I will be honest, in my clinical practice, I don't see a whole lot of families having ongoing conversations about sexuality with kids throughout the ages. Oftentimes you just hear about, oh, have you had that birds and the bees talk? Or have you had the talk? Often it comes up way beyond maybe what a child should. Thinking about the saying, I don't know if there's, I don't have the reference to this, but if it's 8, you're too late in terms of talking about sexuality. So those conversations of what sex is, or sexuality in general, happening at age 8 on average. So the prevalence rate of adverse childhood experiences in male adolescents that cause sexual harm. I'll kind of let you peruse through this slide. However, noting that emotional neglect has the highest prevalence rate of ACEs within these adolescents. Again, this is focusing primarily on adolescents, but we think about, if we don't intervene and don't help children recover from trauma experiences, what are things that could happen? These are the risk factors that go into this. So another aspect of ACEs in here. So emotional neglect, the next highest one being the peer emotional abuse, physical neglect. But interesting to note, sexual victimization coming in towards the lower end of these ACEs. I know it might sound counterintuitive, but the research points out that physical abuse, power and control, oftentimes shows up more in kids with problematic sexualized behaviors than them being sexually abused themselves. So I won't go into a ton of the details on this. I think you guys might have some more insight into this than I do. But what I do want to really focus on in here, though, is the brain regions that are affected with trauma. So the prefrontal, of the many, but the prefrontal cortex, the hippocampus, and amygdala. But when we think about trauma's impact on kids with problematic sexualized behaviors, kids who experience trauma have the risk of developing emotional, behavioral, management, impulse control because of impact to the prefrontal cortex. So we see challenges with judgment, organization, reading, environment, and social cue problems with attention, problems with lying, problems with agitation. When I think about treating these cases with problematic sexualized behaviors, and we talk about, how did we get here? How did this happen? We think about the narrative, the trauma narrative that's happened to them. Oftentimes what you'll see is this was not a incident of a child wanting to cause harm to another child, but it was a child who struggles with the impulse control, struggles reading environments and social cues, maybe not understanding how someone else feels when they've hurt somebody else, or just not understanding, having the judgment of the situation, knowing what's actually helpful. So when we think about how trauma affects these kids, this is where I work here, is the trauma-focused cognitive behavioral therapy side. So all the kids that I treat with problematic sexualized behaviors have some sort of trauma happen to them. And so in my treatment modality, which I'll talk about later, focuses more on the trauma of what's happened to them and not what they did. Because we want to see, I see trauma in that modality as more of a symptom, or problematic sexualized behaviors as a symptom, versus as a symptom of trauma, versus separate of their trauma. And so when we treat the trauma, we also are focusing on treating the symptom of problematic sexualized behaviors. Sexually explicit material. So pornography fits within this. SEM does not cause problematic sexualized behaviors, but there is a relationship. 9 out of 10 boys and 6 out of 10 girls before the age of 18 will see some sort of, or be exposed to some level of sexually explicit material. That again accounts for pornography, accounts for sending or receiving sexually explicit messages, they're known as sexting. What we see is 57% of teens seek out sexual explicit material monthly. 23% have reported having or sending a sexually explicit text message. When we think about pornography itself, 39% of boys and 23% of girls have seen some sort of sexual bondage online. I'll just go to the next slide and I'll talk about all this together. When we think about pornography as a whole, we see about over 88% of pornography, or what pornography is viewed by teens, contains some act of physical aggression or some level of verbal aggression. So when we think about teens, especially kids, teens who are seeking out pornography on a daily basis or a monthly basis, what are they learning about sexuality from pornography? What is porn teaching kids? It's teaching that sex is violent. It's teaching that sex doesn't involve consent. Most pornography does not involve consent. It also does not involve any form, does not really involve any form of contraceptives, or any, in that case. And so thinking about, this is what porn is teaching kids. And so when I ask parents, like, hey, are you monitoring your child's social media use? Are you monitoring their internet use? And they tell me no, or they say, well, I put some parent restrictions on there. I would say, hey, maybe that's not enough. Maybe we need to look at more. And then when we talk about porn, that gets even more uncomfortable for some folks, and that's okay. But that's where we educate, when we talk about that. And we talk about, hey, here's the reason why. Because if you aren't talking to your kids about sexual behavior, and you're not talking about your family values or the expectations or what's normal, what's not normal, somebody else will. Porn will teach that. Their peers will teach that. A stranger will teach that to them. And so keeping that in mind, who do you want to learn this from? Who do you want your kids to learn this from? Do you want it to learn from your medical doctors, from your from a mental health therapist, from you as a parent, or do you want the internet to teach your child? So I'm focusing heavily on this because there's a need for it. We don't talk about it enough, and it's something that I think parents could benefit in more educating. All of us could benefit from learning a little bit more about, what is porn teaching us? What is it talking about? And for kids, a big thing in talking about it is there's also a lot of shame and guilt associated with kids who view porn. And so being able to talk about its impacts, being able to have those healthy conversations about what it is, adult entertainment, it's not real. It's not to be learned from, but it's also not for kids, especially. And it's illegal for kids to view it before age 18. I didn't put a slide into this, but there is a website for teenagers, especially, I think it's 14 to young adulthood, called whatsok.org. It's a fantastic website that focuses on an anonymous question asking to licensed professionals that answer those questions, like, what's okay? Is it okay to view porn? Is it okay that I can't think of, they have all different questions on there, but it's that question of what's okay? Is it okay to have these thoughts? And they take more of that person-centered approach and not vilifying those thoughts, but recognizing, hey, we can challenge our thoughts. No, that's not okay to have those thoughts. about behaviors with kids. There is treatment, there is resources that can help you. So that's whatsokay.org. Fantastic resource. I do have another one for parents on and professionals on sex education that has plenty of videos and resources. There'll be some QR codes that we can scan at the end. Okay, transitioning back. Behavior is what we observe. So these are the problematic behaviors that we see. The family, the impact of the family, the impact of the schools, sexual behaviors, non-sexual behaviors, delinquency, verbal, self-harm. Man, I working with kids is one of my biggest joys. I love working with kids and teens, love working with parents and families. But I've always kind of had the mentality, especially when I worked in residential, is these kids have this hard exterior on the outside, but when you really get into them and you really start talking to them and break down those barriers, you start to see they are just a child on the inside. They've had some really hard things happen to them, maybe it's in the residential context, but they're really great kids. And we have to look beyond the behavior, see what is the behavior telling us, what is it teaching us, what are we learning, what are we learning from, and going from there and understanding that. So understanding what's below the surface of what we see: trauma, these adverse experiences, moral injury, brain development, system and generational trauma, all things that we could make an entire other slideshow on and education on, especially like intergenerational trauma or system trauma. Attachment, how do we make our attachments to adults and others, creating that healthy attachment, nonviolent relationships, attachment style, creating accountability. And then the neuroscience, self-regulation, responding to social cues, information integration. When we think about treating these kids in my office, I'm looking at, this is what you're showing me. Here's what I'm trying to understand about you. What is below the surface in this? And that's, I think, the joy of my job, truly, that I love the most. So what do we do? First, well, evidence-based interventions, multidisciplinary teams approach, and keys to successful treatment. So I know a lot of this might not apply to you guys, but I think a lot of it will be good information of knowing and teaching and talking to parents. There's not a ton of therapists who do TFCBT for problematic sexualized behaviors, or there's not a ton of cognitive behavioral therapy, problematic sexualized behavior therapists. And so thinking about what are the keys to success, that's why I have these slides in here. But when a parent comes to me or parent comes to our office and we are trying to assess what is problematic, I'm not just saying, are these behaviors okay? But we're assessing the entirety of the person, of the kid. So we're looking at a depression, anxiety inventory, a screener for sexual behaviors, parenting approaches. We're looking at protective factors. We're also looking at trauma. Has trauma been impacted into this? What's the connection to the behavior with trauma? Also then the psychosocial assessment. So this is asking a ton of different questions to get to know the family, get to know the child, but we're also including a sexual development history for the child. It's kind of uncomfortable, I'm not gonna lie, but you learn how to become comfortable with that, because if you show uncomfortability, the child gets the message that this is uncomfortable, we can't talk about this. So sometimes it's not even nodding your head while they're talking, it's just staying straight. It's being like, hey, this is a conversation we're gonna have. It's okay. It's not uncomfortable. Well, it is uncomfortable, recognizing the uncomfortability. But usually when I have these conversations with kids, asking, at what age did you notice that boys and girls are different? Or what age did you notice that, we don't touch kids. We don't touch other kids without asking permission. Where have you seen sexuality? Do your parents show any sort of affection to each other? And those kind of questions. So it's really more progressive in the conversation. So we start small and then we don't just dive into what porn have you seen? How have you learned sexual behaviors? That's just not that approach. We start small and work our way up. And with that too, the pornography consumption inventory, I haven't used this a ton. However, I do like it a lot. It's just called the PCI is what you can find it, but really it focuses on not vilifying the child for seeing porn, but saying, what are you learning from this? Are you learning that violence is okay? Are you learning that consent isn't needed? So being able to assess this. So in my approach, we do assessments at the beginning, 3 months in, and then at the end of treatment. Would strive to do that at least. In each of these domains that we're measuring. One thing I want to add in too with that problematic sexualized behaviors inventory, ASBC is a newer assessment. It's just called Assessment of Sexual Behaviors, child version. It's newer. The previous ones And a lot of, like I said, a lot of the research don't account for the impact of pornography, don't account for high-speed internet. A lot of the research that was, when it was done on problematic sexualized behaviors, didn't have high-speed internet. We were talking about kids accessing magazines, pictures online. It wasn't the, I can access on my smartphone and search porn and find millions of images in seconds. This is where we get into some different territory, and where a lot of this research has shifted more towards is the impact of high-speed internet, smartphones, tablets. That's what I was going to talk about before too. Kids can access these things. As there's an internet connection device, kids have access. I've heard of kids finding access to videos on like a Roku device, like on a TV, being able to search just from there, from Kindles, from tablets. And so when we talk about like setting up parental controls, it's not just setting up the parental controls, but it's the active monitoring. And you're teaching kids how to use the internet safely. Like this is a whole other environment that we're teaching kids safety in. When parents tell me they have kids, their kid, they just let them roam on their device, it's like giving your kid to a complete stranger online. And so being mindful of that. Or I won't vilify any specific apps or video games. However, I do want us to be cautious on when kids have access to chat rooms, being mindful of being able to watch those chat rooms or be able to see what's being talked about. Man, kids are smart. They are able to get by these guidelines, and so are adults who want to victimize kids. They also know how to do these apps and chat rooms much better than we do, and much better than the kids do too. And so being mindful of that, increasing the supervision, greatly important. To note, psychosexual evaluations, I made a mention of that. So I want to specify in the assessment period. So a psychosexual evaluation, oftentimes these are initiated through the justice system. These are full-on reports that are done. They have a clinical interview, the collateral information, there's standardized psychological testing, there's a risk assessment. That's important to note. Oftentimes these psychosexual evaluations focus on risk. Are they at risk for perpetrating, for initiating? Are they at high risk? Are they at medium risk or low risk? That's kind of tough to manage once that child is, 2 years down the line. I can't speak heavily on psychosexual evaluations because I'm not trained in them. That's a whole special level of training, and oftentimes done by psychologists specifically for the psychological testing, also variable by state and court dependent. So these are a resource and a tool. We've been using them for a long time now. And so when you think about, does a kid need a psychosexual evaluation? Something to always consider. We'll talk about that at the very, very end in terms of local resources for here in Sioux Falls. But the nice thing is that it does come out with the final report and treatment recommendations. Generally, this is really dependent on who does the psychosexual evaluations. But there is obviously the cost of the testing and then the separate cost for the report itself. When it's court mandated, the court receives that report. When a child is brought in or the parents go in to talk about psychosexual evaluations or have that, then they pay for that report for themselves. Okay, so what do? Evidence-based treatment. We have three major approaches to treatment. So the first is problematic sexualized behaviors, cognitive behavioral therapy. This is for ages, school-age kids 7 to 12. And then there's an expanded training, expanded understanding for kids 9 to 14. So again, this is really addressing what are those problematic behaviors. This doesn't take into account the impact of trauma, though most therapists will. The difference between this approach and the approach that I utilize is focusing more on the impact of trauma, doing a trauma narrative. I'll talk about that in a little bit. But this is problematic sexualized behaviors, cognitive behavioral therapy. It's also oftentimes done in a family setting. It's done in individual. It's done in group settings. So evidence-based treatment for this age range. For adolescents, this is that 10 to 17 range. What we find to be most effective is what we call multisystemic therapy for youth with problematic sexual behaviors. So MST-PSB. How I understand this is it's a multi-level approach. We're not just focused on the kid as the behavior problem, but we're also seeing them in their whole environment. What's things going on at school? How can we involve different stakeholders involved in treatment? Which is why it's not just for teens only, but we go to the 10 to the 17 range. So we really look at the youth as a whole. And then lastly, the other evidence-based treatment is this trauma-focused cognitive behavioral therapy for children with problematic sexual behavior. Ages 7 to 12, or 3 to 12 is what age range is. TFCBT can be done with kids as young as 3 years old. And then once we get into with traditional TFCBT, we go up to age 17, 18 in terms of treatment for trauma. However, with PSB, because we're looking at problematic sexualized behaviors, that is the ages 3 to 12 age for TFCBT. And that's a whole nother presentation. I would love to talk more about what I do and how we treat trauma. I think we talk a lot about what trauma is, but I don't think we talk enough about how do we treat it? How do we actually work with trauma? But TFCBT, PSB focuses on treating the problematic sexualized behaviors as a symptom of trauma. Now, as I mentioned before, there's a number of therapists in the community who treat PSB in kids and adolescents. To my knowledge, I don't believe they are trained or know or have the training in this. However, they do some really great work. They might take more of an eclectic approach to treatment. So they're taking bits and pieces from other areas or from different types of therapies, education, family therapy, all those different areas. Or there's a program called Pathways, I believe. And so we have some really great clinicians in Sioux Falls who are treating these behaviors. I'll be honest though, there's not many people are in this area. There's a great need for it. There's not many people talking about problematic sexualized behaviors because it's uncomfortable and we don't want to. It's really thinking about what can we do? This is the idealized. The actual reality is a little bit different, especially here in the local South Dakota area. We just don't have many resources, but we'll talk about that at the end. Multidisciplinary team approach. These cases really require multiple levels of involvement. We got court, we've got medical, we've got therapy, we might have foster care, child welfare. So the importance of having multiple stakeholders collaborating together. I think we all know how important multidisciplinary teams are, or interdisciplinary teams. Same thing with this treatment level. When I treat kids with PSB, I'm not just working with the families, but I at least try to work with other stakeholders as well. Not that they need to know all the details, but recognizing like, hey, this child exists at home and they exist at school and they might exist at a summer camp. How do we allow them to be in those environments safely? And so safety planning, which we'll talk about soon. So what makes treatment successful? I'll kind of go through these pretty fast here. I apologize for running out of time. So these are what we do know is outpatient treatment works. In fact, it's better when we have a child stay in the home, if at all possible, and safety allows for it, and more specifically in the community. When we just ship these kids off to residential or inpatient, that can be helpful, but we really want to focus on, can we treat this here locally? Can we treat this in the community where they exist in? We see far better outcomes when we can do that. So we see active and full participation in treatment with parents and caregivers. It's not just a child that's a problem, but it's, hey, we got some things we can work on in the family unit. How can we all work on this together? Short-term treatment, approximately 3 to 6 months. These cases don't really need to be in therapy for years and years and years. We can treat them shortly. And when we have, especially when we use those evidence-based treatments and approaches, it's possible when we have the skills and the practices are known. And the kids are practicing those sessions practicing skills between sessions. So we want to also increase and enhance family relationships, education, parents, and addressing sexual education topics with kids, their children, and their parents. That's not in there. And then also support abuse prevention strategies and skills. So takeaway tips, treatment that involves parents and caregivers. So this is maybe to keep in mind, if you want to take a picture of this, you certainly can. Or the National Center of Youth Sexual Behaviors has this. This is straight from their website in terms of how do we intervene with children, like tips for this. Treatment that involves caregivers and parents. Community treatment. Again, not all children with problematic sexualized behaviors have been sexually abused, which is why I don't work with every child that comes with sexual behavior problems, because sometimes they don't have a trauma background. And that's where we need some additional resources and support with some more like problematic sexualized behaviors, cognitive behavioral therapy. Again, if sexual abuse is suspected, we make that report. Even if especially if this gets a little bit tricky and hard, but sometimes a child will, tell me that they have sexually abused somebody else, it's not just the one person that was reported, we still report that. And that's a part of our process when we talk about consent in consent to therapy. And when I work with families, we talk about that could be a reality, but we're not trying to get you in trouble, we're trying to help. And that's more on the language that we try to use. Again, multiple factors contribute to PSB. Focus on the protective factors. We'll get to that. Adolescence, I'll kind of let you take a look at this real fast. This is a family focus, least restrictive. We want to put kids in the least restrictive environment as possible, minimize any false assumptions, multidisciplinary approach. So what are our protective factors? These are our healthy boundaries supported and modeled in the home. We have protection from harm and trauma, parental guidance and supervision, healthy friendships, open communications about feelings with a trusted adult, successful experiences and skills, adaptive coping skills. These are the things that we work on in therapy and we want to teach with kids. And so if we can help encourage these protective factors in our kids and teens, we're setting them up for success. I want to highlight the successful experience and skills real fast. That is such a valuable thing for kids and teens, is finding them. Like, what are you good at? Why not all be star athletes, but what are we good at? Is it writing? Is it poetry? Is it cooking? And really seeking that out. And even if you only get 5 minutes with a kid, I would highly encourage that you make that focus with your connection with them, is what are you good at? What do I get to know about you? What's one fun fact you want me to have about you? Okay, recidivism rates. I'll just highlight this one really fast in here. So over the last 15 years, what we found that is between 33 studies, so this is Cadwell 2016, it's a pretty big study within the recidivism rates for sexual behavior in adolescents. But what we find is that the mean recidivism rate after treatment is only about 2.75%, meaning we can do something about this. We can actually help these kids work on these behaviors, these adolescents. Even if it shows up, we have 2% recidivism rate is a pretty nice thing to keep in mind. Recidivism rate for non-sexual delinquency, so these you name it, what comes to mind, stealing, we'll just say that, 30 to 40%. Given that's probably not in that number, but that's my mindset in here, is recognizing that even treatment after non-sexual delinquency, 30 to 40%, versus when we treat, sexual recidivism rate goes down to that 2.75%. So treatment is possible. These kids are not going to be, if we label them as sex offenders, we give them that expectation to become sex offenders. And so that's why language is so important. So as I said before, we're planning, creating safety plans with these kids. Maybe I'll just click through all these. If you want to take a picture of this slide, you can. So Jeff Sidoli, he is someone that's trained me in the problematic sexualized behaviors treatment with TFCBT, and phenomenal in this work and research, but really focusing on planning that includes structure, awareness. We're looking at relationships, treatment, and access to sexual explicit materials. So really focusing on that within the home life. So what can you do to help? Trauma-informed practice. I'm sure we've all heard this language many, many times, but I want to highlight the fact that language matters. It's not what's wrong with you, but what happened to you. Seeking to realize and understand the impact of trauma and understands path for recoveries, and understanding signs and symptoms of trauma in our patients and our families, and even in our coworkers and our staff that we work with. Integrating knowledge of trauma into policies, procedures, and practices, and avoiding re-traumatization. We could talk about a whole other slideshow on that one too, about re-traumatizing, whether that is through the language that we use, through how even like asking consent before we even touch a child, or giving them options. On a previous presentation I did, we talked about how if you have to give a shot to a child, this is just an idea that we have, is, which arm would you like to use? You give them some of that control. It's not, do you want this? But it's, hey, we have to do this. Which arm would you like? Give them some sort of control and sense of control. Encouraging education for parents, the birds and the bees talks, not just one conversation that's done at age 16 after a child has already, but really thinking about how can we start these conversations even as young as age 4 and going on, or even as young as age 2, and talking about our bodies, using language, like I said, penis, vagina, scientific language, acknowledging parent discomfort. This is uncomfortable. Discussing technology use, destigmatizing these cases. Here's some resources up here. Amaze.org is that education website I was telling you about. Fantastic resource for parents in education and professionals as well. Oops. And then I think I'll leave this slide up at the end too. How much time do we have? Got 5 minutes. Let me go through, we'll come back to those. Let's try this one. Maybe let's just try it real fast. Take 2 minutes, literally 2 minutes to see if this works. It'll help me for future presentations. Go ahead and scan this. So this is the case. Case 1, we're gonna use Anna. I'll be having you guys decide, is this normative, concerning, or harmful? So I'll read it. Anna is a 4-year-old female who was found in her 2-year-old brother's crib. Her brother's diaper was off and she was touching his penis with her hand. Mom further reports that her daughter was often walking in on her in the bathroom while she was changing when told not to. Daycare also reported that the 4-year-old was walking in on other children in the bathroom to ask about their private parts. Caught touching her vagina in certain play areas. Daycare provider has attempted to redirect. Let's see, does that open up for you guys? Did it work? All right. Okay. Give it a couple of seconds here. And if it doesn't work, okay, well, I think we'll probably just close it. Is that okay with that? All right. Yeah, actually, I'm gonna side with the normal one on this one. I know that sounds crazy, right? But let's think about it. The age difference isn't incredible. It's the 4-year-old to 2-year-old range. I guess where maybe I tripped us up in here is I added in that line into the daycare providers attempted to redirect. I can see where that is tricky in there. And so maybe I would say concerning, normative, depending on how this was phrased in here, obviously there's more factors in there. But if we were to exclude that last part in there, the daycare providers attempted to redirect, what's it?
You follow up that. Yeah.
Yes, before that sentence, we would say that that is, normative. But once we add in there, daycare providers, other places, that is concerning. So actually, I will agree with you guys now. And that one, because I did change that right before I came here, so I apologize. This one, I know this is pretty graphic. However, these are the cases that we work with. So let's look at this one. 10-year-old male in foster care due to reports that he put his mouth on his 8-year-old brother's penis and 6-year-old sister's vagina. He has also digitally penetrated her vagina and an 8-year-old brother's anus. Other siblings were removed because mom's boyfriend was physically abusive to everyone, and he, the boyfriend, had a history of sexually abusing his sister as an adolescent. What are we saying? Yeah. Yeah, so at 10 years old, we would say this is problematic, primarily because we're seeing adult sexual behaviors at a 10-year-old range. Anything that is penetrative, anything that is oral related, we would say that those fall more into the harmful side. There isn't a whole lot of mutuality that comes with those behaviors. And so really being mindful of, is it oral related? Is there penetrating, objects, fingers? Especially with objects, we would say that is automatically harmful. Not automatically, but we would really consider that being harmful. Okay, last one. 14-year-old male brought to therapy due to mother of the patient walking in on the youth. Mother reports that the youth was masturbating in the bathroom. It's 14-year-old. Mother also reports this happened 1 to 3 times in the last 3 months. Mother has indicated that she had found a search history of pornographic material in the last week. Previous reports of physical abuse have been reported. That's what that should say. So 14-year-old caught masturbating in the bathroom 1 to 3 times. Previous history of physical abuse, seeking out pornography online. Yeah, so I was kind of trying to trip us up on this one. This is, we would say, normal. This is normal behavior. In fact, what I would say is more concerning is mom walking in on the boy 4 times or 3 times. I would say that's a little bit more concerning than anything else. But when we think about, is this normal behavior? I would classify this as normal. Maybe we could do some education with the teen, but maybe more education with mom on privacy rules. Just an idea. Okay, real fast, I'll leave this up here. Local resources. What can we do about this when a parent comes to you and says, hey, I have this problem? Well, we'll break it down. Young children, children, adolescents, young children, age 3 to 6, outpatient, various therapists. We don't have any providers in South Dakota that treat PSB CBT. That's the non-trauma version. Nor do we have anybody with MST, PSB, and then there are very few. As of right now, I believe I'm the only therapist who has the advanced training with TF, CBT, PSB. However, there are other therapists that have that training in North Dakota, in Minnesota, Iowa. But when we talk, about South Dakota only, there's just not a ton of resources yet, but we're going to change that shortly. We would love to see that be changed, more education, more training for therapists, and more education for all of us. Residential treatments, if needed at all. I put stars here because I know them from previous experiences working with them, that these are resources that we have in our state. However, I don't know if they specifically treat sexual behaviors, but regardless, that's what we have for PRTFs. Psychiatric residential for adolescents, our home, Parkston and Huron, they work with they call them sexually aggressive kids or teens. So that's an option. Places like other residential treatment facilities might not accept these kids because of their behaviors. So again, more work to be done on how can we work with these kids. And then we have our intensive residential. This is like Aurora Plains and Plankington. This is pretty much the only one in South Dakota that works on the more intensive side. And then we have our out-of-state options that we send kids to when there's no other resources for them. So can talk a whole bunch more on systematic issues with problematic sexualized behaviors, the need for treatment, advocacy. I appreciate if you guys continue being advocates in your own ways of recognizing these behaviors are treatable. We can do something about this. We don't have to just vilify kids and teens and parents. Give them a knowledge and support that we can do something about this. So last bit, resources. National Center of Sexual Behavior in Youth, National Children's Alliance, and the National Child Traumatic Stress Network. Thank you. Appreciate you guys taking the time. And then if there's any questions I guess we're out of time, but if anybody wants to stay and have any questions for me, I'm more than willing to continue talking. So thank you guys. Appreciate the time.